This is Megan Smart's final project for the Patient-Oriented Outcomes class as part of the Doctor of Athletic Training program at A.T. Still University. The clinical scenario I chose for this project was a 20-year-old female volleyball player, Division I scholarship athlete. She's a setter and her chief complaint was recurrent patellar tendonitis in both knees. Her location of pain was the inferior pole of the patella and over the patella tendon itself. Her duration of pain was the past 3 years reoccurrence of knee pain with a recent 3 months of increased pain due to the effects of volleyball season. On observation, there was thickening of the fat pads around the patella and edema and puffy appearance of the knee. On testing, there was noticeable hamstring and anterior tibialis weakness, and her right quad was stronger than her left, and her left hamstring was stronger than her right on isokinetic testing. Her quad to hamstring ratio was 2:5 instead of 2:3, and she had difficulty balancing due to her arches collapsing. On the single leg squat test, both legs had hip drop, and her left leg went in. Our short-term treatment goals are to decrease pain, specifically in activities of daily living, along with decreasing swelling and scar tissue. We'll do this through scar massage, stretching, rest, and ice. Our long-term goals are to improve her biomechanics by minimizing the strength and proprioceptive deficits we found in the testing. This will help improve her long-term health care. We'll do this by using an evidence-based patellar tendonitis protocol with eccentric exercises, using correctional exercises, and improving her isokinetic measurements through exercise. When we look at this injury through the disablement classification model, we see that the health condition is patellar tendonitis, which affects the body function and structures. This is decreased patellar mobility, pain, decreased quadriceps function, swelling, and scar tissue. This affects her activity level, which is pain with stairs, walking long distances, squatting, jumping, and running. These in turn affect her participation of her discomfort walking to class and at sorority events, inability to finish practice strong or fully participate in the weight room. Other factors are environmental factors, which are her athletic scholarship, the new athletic trainer she's working with, pressure to return to athletics, and her sorority expectations. Her personal factors are that she's a 20-year-old college student, a sorority member, a Division I athlete, and her classes are far away, with stairs being the most convenient route, of course. Her critical mindset towards rehab and type A personality are also factors. The primary health-related quality of life concerns of this patient are that her patellar tendonitis is decreasing her athletic performance, she has pain and stiffness throughout the day, and her pain is limiting the social events she participates in. The outcome instruments I chose to evaluate for this patient include the knee injury and osteoarthritis outcome score, which utilizes 42 items and 5 separately scored subscales. This instrument takes about 10 minutes to complete. The second instrument, the Knee Outcome Survey Activities of Daily Living, is a 17-item questionnaire and takes about 5 minutes to complete. At a glance, both are specific to the knee and have basic scoring. However, the COS Activity of Daily Living is shorter and less wordy, while the COS factors in higher activity levels. Both of these instruments have high reliability, with the COS Activities of Daily Living having a higher score. The COS, however, has each individual subset that has reliability ratings. This includes the Sport and Recreation section, which the COS Activities of Daily Living does not evaluate. This can be helpful if you want to use specific sections that apply to your athlete. When it comes to responsiveness, the COS has more responsiveness with a higher activity level, which is important for this patient. And the COS Activities of Daily Living loses responsiveness over time since it factors in activities of daily living instead of the higher functions of a Division I athlete. As far as acceptability, neither have a ceiling effect for general knee pain or injury. The COS Activities of Daily Living has been found reliable for patellar femoral pain syndrome, which is more similar to this patient's injury, and it has a MCID of 7.1. The COS has an MCID ranging from 6 to 12 points for the Sports and Recreation subscale. Ultimately, I decided I would use the Knee Osteoarthritis Outcome Survey for this patient due to the activity measurements and responsiveness over time of this measurement. I would use sections as goals and take away sections as the goals are met. For instance, when she scores a 0 on the pain section, I can take that section off. Since reliability and retest scores are individualized for each section, this helps me in utilizing it. As far as timing, I would use it in postseason, the start of December, prior to Christmas break, which would be 2 weeks later, weekly during Christmas, and on return from Christmas break and weekly thereafter. Time to take it should decrease as sections are taken away. It can improve my communication over Christmas break, as it is much easier to give them the survey and then ask, "How are you?" or ask all of the questions necessary to change their rehab. Since the reliability for sections over time can be used and compared in and out of season, it will allow me to show her progress throughout the year. If she does have flare-ups as the season restarts, I can add sections back and see how her scores looked compared to the year before. In implementing patient-oriented outcomes into my clinical practice, I have several positives. I have flexibility in what I'm allowed to use in taking care of the patients on my team, a limited number of patients in comparison to some clinical settings, and that I have about 16 volleyball players and about 80 cheerleaders. All of my patients have access to computer and Wi-Fi on campus and in study rooms. As far as barriers, time is usually limited in season, with athletes rushing from class to tutoring and sometimes sorority events. Our practice times and locations also change frequently, which decreases the consistency in our pre-practice routine. I also have no control over implementing computerized system for data collection. In order to overcome the barrier of time being limited in season, I can use single measurement outcome instruments prior to practice, look over these scores during practice, and if these scores have changed significantly, I can catch athletes for a more detailed update later. I can also attach specific outcome measurements to rehabilitation forms for my long-term rehabs. I can do this on a consistent basis so that each patient knows when these forms need to be completed by without having to remind them. Since my athletes don't do well with lack of consistency, and I can't control practice times and locations, I'll have a very organized binder with extra forms in each location, and I can even carry one in my car in case we get a random practice site. Since I have no control over implementing computerized systems for data collection, I can use paper versions and scan them into our current injury documentation software. Overall, I feel patient-oriented outcomes can improve the communication between my athletes and I. I feel they can help patients feel better listened to, despite time restraints and rushed verbal answers. It's also great for my competitive population, who thrive on seeing improvement over time. This class has helped me gain a better understanding of instrument selection, as has been a hindrance to me in the past. I had no idea how to choose a measurement, or that there were so many to choose from. I started using them in my clinical practice, but I believe it will take time and consistency for it to run as smoothly and have the influence I hope for it to have in the future. This concludes the presentation, and below are my references. Thank you for taking the time to look over my final presentation and listen to this PowerPoint. I look forward to hearing your input, perspectives, and any questions you may have.